So Dr. Teslakian segued nicely to my topic, so who should get IVC filter retrieval evidence-based approach. These are my disclosures. So are there guidelines? As we just talked about, SIR has put out these guidelines, and this is where we got most of the evidence for retrieval. So the panel consisted of 3 IRs, 2 vascular surgeons, 2 physicians that were boarded in vascular medicine and cardiology, and then 1 vascular medicine, 1 pulmonologist, 1 hematologist, and 1 trauma critical care surgeon. They provided evidence-based recommendations on the use of IVC filters. They reviewed 3,259 abstracts and then ultimately used 34 studies that provided the evidence base for these guidelines. And then agreed on 18 recommendations for placement, or total placement and retrieval, 5 of which pertain to retrievals. So why do we retrieve? As we talked about all day, device-related complications. The FDA received over 900 reports of adverse events associated with IVC filter implantation, the most common being migration and embolization, leading them to issue guidance. There's an increased risk of DVT and cable occlusion. And with the advent of advanced retrieval techniques, these allowed for complex retrievals. In 2015, DSI reported that retrieval can be performed regardless of dwell time with failure rate of less than 3%. So when to retrieve? The FDA issued guidance saying risk to benefit ratio begins to favor IVC filter removal within 29 to 54 days after implantation if the risk of PE has passed. And then the SIR recommends removal of retrieval IVC filters when risk of PE is mitigated as early as retrieval is considered safe, so when anticoagulation is initiated. Due to limited evidence, routine removal of permanent IVC filters is not recommended according to the SIR. When do I retrieve? After reviewing the patient's clinical history and imaging, retrieve at low risk of retrieval and long life expectancy, and if there are filter-associated complications like we talked about. So should those with complications associated with IVC filter undergo retrieval? Sort of talked about this earlier. SIR recommends in patients with complications attributed to the indwelling IVC filters, they suggest removal be considered after weighing filter versus procedure-related risk and the likelihood that the filter will be removed. If the filter is removed, it will alleviate the complications. The panel agreed that symptomatic complications such as penetration, pain, embolization, or infection are unlikely to improve with conservative management. Therefore, filter retrieval is warranted, however, the procedure may be more complex. It should only be done by physicians that are experienced with advanced techniques, and the ongoing risk of venous thromboembolism and PE should be assessed with the management plan in place after retrieval. So what are some of these device-related complications? Again, we've talked about this throughout the day. Filter perforation. It's when the filter component penetrating more than 3 millimeters of the vena cava wall, which can be seen on CT or venography. Filter component fracture, structural failure of a filter. Intravascular fragments have a high risk of embolization. Cardiac embolization can lead to malignant arrhythmias, cardiac perforation, tamponade, and then ultimately death. And iliocaval thrombosis leads to severe edema, pain, lipodermal sclerosis, and stasis ulcers. Benefits and harms from retrieval of filters that have symptomatic complications. Removal alleviates symptoms and prevents future complications. However, the harm is if the symptoms are not alleviated, we perform an unnecessary procedure in removing this filter. So who should not get retrieval? In certain clinical situations, those are severe morbidity and short life expectancy. Venous thromboembolism recurrence while under anticoagulation, patients with high hemorrhagic risk with venous thromboembolism, long-term contraindication to anticoagulation, and long-term immobilization. Structured follow-up, I think, is necessary for retrieval. So overall retrieval rates have risen in the last few years. However, it's still very low. Approximately 18% of the Medicare population have only gotten retrieval. As endovascular physicians, dedicated plan to follow up patients with IVC filters should be in place. We need to determine when patients are ready for retrieval. At our institution at Cornell, we have a IVC filter clinic number, which is embedded into the report when we place the filters so that other clinicians can see if for some reason that patient gets lost to follow-up in our institution or moves on to another location. And then our advanced practice providers set reminders in Epic to follow up and chart review all the IVC filters that we place. So workup for retrieval, imaging or not, Dr. Teslakian touched on this. The SI panel recommends in those patients who are having filter removed or converted, they suggest against routine pre-procedural imaging of the filter and use of laboratory studies except in select situations. What are those select situations? Prolonged filter dwell time beyond several months. This is a review article that reviewed 259 retrieval attempts. They define challenging as a dwell time greater than 50 days, and then those that failed retrievals were more common after 90 days. Another select situation is those filters with substantial tilt or the tip embedment is unknown. And then patients with lower extremity DVT, abdominal pain, GI bleed, those need to have proper workup to ensure that advanced techniques are available. In my practice, I think what we do is any outpatient retrieval gets a lower extremity duplex sonography and a CTV. We use that to help plan out the retrieval in terms of tilt, fracture, and penetration. It also helps us plan out the day and book the right amount of time and what equipment we need to use. So in summary, evolution of guidance on when IVC filters should be retrieved has evolved since the FDA first issued guidance in 2010. Attempts at evidence-based guidelines such as the SI consensus panel in 2020 have helped, but more is needed. IVC filters should be removed as soon as the PE risk is mitigated, and further trials such as the PRESERVE trial will help in providing more guidance in the future. Thanks.